quickly because I think the discussion is the more interesting aspect, and you all know the data. And I had a lot of coffee, so I think I'll go. So that's my time. So just summary, ALK positive non-small cell lung cancer represents 3 to 7% of non-small cell lung cancer. There are multiple different ways of detecting it, IHC, FISH, and now next generation sequencing. As we'll get to, there are multiple ALK variants identified where the question on differential response based on the variants is starting to come up. And there are currently 4 FDA-approved ALK inhibitors and 1 third generation that's in breakthrough designation. That's ceritinib, alectinib, crizotinib, brigatinib, and lorlatinib. And of course, when you have so many drugs on market for a relatively rare disease, the question comes up, how do you sequence these? What's the best way to treat these patients? So just to run through some of the data as a baseline for the question. So obviously the first TKI that became available was crizotinib, and I just put the profile 7 and 14 here, demonstrating improved response rates of about 60-70% over chemotherapy, improved PFS with no real OS benefit likely from crossover. However, all that great prior data we had is probably outdated now because of the ALEX and JALEX study, taking newly diagnosed patients and comparing alectinib 600 milligrams BID to the standard crizotinib dose with a primary endpoint of PFS. Presented at ASCO, I believe, first last year. This year. So we all know the hazard ratio for PFS was 0.47 in alectinib's favor. And it benefited all subgroups examined, and importantly, did much better in preventing future CNS progression. So still talking about first line then, just get all the players on the block. Ceritinib has also now been approved in the frontline setting based on a PFS benefit over chemo frontline. So the question, hard to know how this is making the market given that its comparator arm was not crizotinib, but it is an option in first-line patients. And then don't want to go through an individual slide for every study, but in this post-crizotinib era, we have 3 drugs approved: ceritinib, alectinib, and brigatinib, all with impressive results in that second-line setting. There's no, unlike EGFR, there's no selection at this point for these agents. So I want to spend a little bit of time, just a few seconds, on lorlatinib. This is the first third-generation agent approved in study, got breakthrough designation. Their trial is a little complicated with all the different arms, including, so there's treatment-naive arm, prior crizotinib, or another ALK TKI, but allowing for chemotherapy, 2 prior ALK agents and 3 prior ALK agents. And they're all studying in ROS1. And to highlight the pertinent results released, so response rates were impressive in all the arms. I think the important one here is, if you look at the cohort 4 and cohort 5, these are patients that got multiple TKIs, second-generation TKIs, still having response rates of almost a third of patients, which is promising. Continue these patients on TKIs rather than having to switch to chemo or other agents. So the question starts arising with all this data out, how do you start selecting for which drug to use? I think there are certain things you can look at to help make the decision. One of these is CNSZ. So 30% of all ALK patients present with brain mets, and over the course of their disease, almost 60 to 90% develop brain mets. And you can see some of the numbers I pulled from the studies. The main studies show good CNS penetration for all these second and third generations, while crizotinib does not have good activity there. Now these numbers depend on if they got prior radiation before, if the patients, what line. So these aren't the exact numbers of brain radiation. But you can see they all have some good CNS response. A similar story to osimertinib. So you also want to think about the toxicities, and while there's a lot of overlapping toxicities between these agents, they each have certain ones they have to look out for, and that might help select what would be the best ALK drug for these patients. Because we all know, general GI toxicities, the CMET class activity of swelling, and they have some visual toxicity as well, double vision kind of floaters. Compared to alectinib, alectinib was better tolerated in general. I mean, they have those same toxicities at a lower level, as well as I think myalgia is one to keep in mind, muscle pain for alectinib. Ceritinib, as is consistent with my personal experience, is pretty hard to tolerate with GI toxicity. Nausea, vomiting, diarrhea is the main thing you have to look out for there, and I'll show a study that might help that. And then lorlatinib, the interesting one is the hypercholesterolemia and hypertriglyceridemia. A lot of patients have to go, most patients have to go to statins that go in this trial, as well as some CNS effects. Keep in mind. And brigatinib, it's hard to read there, but the one I want to point out is, especially at the higher dose, they saw a lot of pulmonary toxicity. That's what I thought it was. So with ceritinib, just an interesting study where they, kind of went back and instead of dosing at the standard 750 fasting, they dosed it with 450 with food. They showed similar PK exposures with much improved in GI toxicity. So something to keep in mind if you do want to use ceritinib in this setting. So just some of the questions to be discussed. So should all ALK variants be the same? We know that there's various variants, meaning the EML4, where it's fused to the exon that's fused to the ALK gene. Variant 1 is, at least in this study by Yoshida, is the most common with exon 13 fused to exon 20. And then there's variant 2, which is exon 20 to exon 20, and variant 3A, which is exon 6A to exon 20. I just gave the percentages in that pie chart. And what they showed was interesting. Clinically, the clinical demographics were about the same, and that patients, this is all patients that got crizotinib that had the variant 1 ALK inhibitor, variant 1 ALK gene, seemed to have a better progression-free survival, showing that maybe there's a difference between the variants. However, I saw some other smaller data that maybe that's not true. Other haven't necessarily found the same results, but they saw relatively small numbers at this point. So I think one of the most important questions is resistance-based testing. Should we be doing like the Tarceva, well, now it's going to be osimertinib, but the Tarceva days where we biopsy on resistance everyone and choose treatment based on resistance? Going to be outdated soon, but in crizotinib, but there's about 30% on-target gene alteration in the ALK gene, as well as bypass tract activation and a lot of unknown. One of the largest series to date by Gaynor and the group up there took 103 ALK-positive patients that had on their most recent TKI, some of them had other TKIs before, and did biopsy results including crizotinib, ceritinib, alectinib, and brigatinib. Interestingly, they showed that the resistance mechanisms to the second generation agents were a lot more on-target based within the ALK gene, especially with the G1202 mutation. You can see here in about a third or more of these patients, while crizotinib is much more rare. Why this is important is, in the same paper, they looked at, this is preclinical, but looked at resistance. The different agents have different ability to target these different mutations. An important one here is that lorlatinib seems to have good activity against G1202. So that gives us some basis to maybe that we can actually be more selective in how we choose our agents. But of course, we don't know how this is all going to change once selected is more commonly used, as I think most of us are doing now. Looking at time biology, so I thought this case report was interesting that Shaw et al. Published. They had a patient, ALK positive, got crizotinib, did well for 18 months, then developed 1156 on progression, treated with ceritinib and other agents, and then finally got placed on lorlatinib on a clinical trial, had some disease control, and then progressed. And when they rebiopsied, the patient had now a new mutation, 1198, found that, and then was retreated with crizotinib and had a nice response for 6 months, showing that as these if you can potentially mutationally select, even go back to the first generations and maybe have being able to continue the progression of these patients longer response. So just and finally, just do combinations, as we have with every target agent. Do combinations play a role in either preventing or bypassing these resistance mechanisms? You can see some of the suggestions here. And then, like we just talked about, what's its role in the in the earlier stages of disease? My summary. So first-line treatment, I don't think is currently controversial. I think it's alectinib right now until we see new data. Should we mandatory? Are we getting to the point where we need to recommend mandatory biopsies upon progression to help select the next agent that's appropriate? Do we treat all ALK variants the same? Combinations, and kind of in summary is what treatment to use when. That's the main, I think, to summarize everything. And thank you.
Next